Kernicterus. This is a form of the bilirubin-induced neurological dysfunction that occurs when unconjugated bilirubin crosses the blood-brain barrier and deposits in the brain tissue, particularly in the basal ganglia and the brainstem nuclei. Excessive bilirubin production, hemolysis, RH or the ABO incompatibility, G6PD deficiency, sepsis or the infection, polycythemia. Reduced bilirubin clearance will be like immature liver enzymes in the preterm or the term neonates. Genetic disorders, example Gilbert syndrome and the Crigler-Najjar syndrome. For the exacerbating factors, prematurity, hypoxia, acidosis or sepsis, increased blood-brain barrier permeability, dehydration or the poor feeding. For the pathophysiology, unconjugated bilirubin, which is a lipid soluble, binds to the albumin in the blood. When levels exceed the albumin binding capacity or in the condition that disturbs the blood-brain barrier, bilirubin deposits in the brain, affects the neurons, causing neuronal apoptosis and permanent brain damage. For the clinical features, acute bilirubin encephalopathy, phase 1. This is yearly 1, lethargy, poor feeding and the hypotonia. Phase 2, intermediate, causes irritability, high-pitched cry, hypertonia, tetracholis, backward arching of the neck. Phase 3, advanced, leads to coma, seizures, apnea and death if untreated. For the chronic Kernicterus, develops in the untreated or inadequately treated cases. Movement disorders like choreoacidosis, dystonia. For hearing loss, sensory neuronal deafness, gaze abnormalities, impairment of the upward gaze. Dental dysplasia, enamel hypoplasia, cognitive impairment, variable severity. Clinical evaluations like jaundice extending below the chest in the neonates. Neurological signs like hypotonia and the obstructors. For the laboratory test, total serum bilirubin levels greater than 20 mg per di or the higher risk, but the Kernicterus can occur at the lower levels in the preterm or the sick neonate. Blood group testing, mother and infant for the incompatibility. Direct and the indirect Coombs test for the hemolysis. G6PD levels and CBC if hemolysis is suspected. For neuroimaging, MRI, hyperintense areas in the basal ganglia and the brainstem nuclei. For the management, preventive measures like routine monitoring of the bilirubin levels in at-risk neonates, early initiation of the breastfeeding to promote the bilirubin excretion, prophylactic phototherapy in the high-risk neonates. For the treatment, phototherapy converts unconjugated bilirubin into the water-soluble forms for excretion. Exchange transfusion used in the severe hyperbilirubinemia or when the bilirubin approaches the neurotoxic levels. Treat the underlying causes, example sepsis and hemolysis. IV immunoglobulin, IVIG in the immune-mediated hemolysis, RH incompatibility. Supportive care, neurological monitoring and the management of the complication, hearing and the developmental delay. Complications like chronic Kernicterus with irreversible neurological damage, death in the severe untreated cases. Kernicterus, this is caused by the unconjugated bilirubin crossing in the blood-brain barrier, affects the basal ganglia and the brainstem nuclei, leading to the permanent brain damage. Risk factors like prematurity, RH-ABO incompatibility, J6PD deficiency and sepsis. Acute bilirubin encephalopathy progresses through the stages hypotonia, hypertonia and coma. Classic features of the chronic Kernicterus, choreoacidosis, hearing loss, upward gas palsy and the dental hypoplasia. TSP greater than 20 mg or di is a critical threshold but varies with the gestational age and the risk factors. Management includes phototherapy and the exchange transfusion. Prevention, early recognition and the management of the hyperbilirubinemia, routine bilirubin monitoring and the phototherapy.